So I farm so hard, the employees wanna find me, and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this ain't easy. Working late nights, you best believe me. My grades can only go A's. Never wanna see another B unless I'm Jay-Z.
What's good, fam? It's your host, Jim Pruitt, aka PharmD Lit Highlight, and I'm bringing you another episode of the Pharm So Hard podcast. We have another one of our EM pharmacotherapy lit reviews that are going to be looking at studies either done by EM pharmacists or by pharmacists that can be applied in the ER. This one's going to be special because I believe that no matter what type of shop you're at, whether it's community, academic, peds, adults, this study can be really applied to you because it's sepsis. We're all dealing with sepsis. It's something that we see every single day, and it's about something that we do every single day that probably didn't have as much data on. So this is going to be looking at the use of clinical pharmacy practitioners in the emergency department and the pharmacist-driven sepsis management, particularly looking at those antibiotics. And this was a really, really cool study. I'm going to make sure I put it in the show notes for you guys and go read it. But this is something that was done by Aubrey, Taylor, Reagan, and all those ladies out there in Caramount. But I don't want to talk too much more. I wanted to let the guest go ahead and introduce herself for today. So guys, welcome to the show, Taylor Kaysen.
Hey Jimmy, thanks for having me on the podcast today. I'm excited to talk about this study and really be a part of the series you've got highlighting great EM pharm studies that have been coming out. So I'm Taylor Kaysen. I'm originally from Augusta, Georgia. I did my undergrad at the University of Georgia, go Dogs. Then I moved to Charleston, did my pharmacy school at Medical University of South Carolina. I did a PGY1 at St. Joseph Hospital in Lexington, Kentucky. And then I moved down to Florida, did a PGY2 at Sarasota Memorial Hospital. And then after PGY2, I ended up moving to Charlotte, North Carolina. And now I work as a clinical emergency medicine pharmacist at Caramount Regional Medical Center, which is just about 30 minutes outside of Charlotte.
Thanks for a quick introduction. Shout out to everyone on the team. Again, it was quite a bit of you guys. Aubrey, Reagan. Shout out to my buddy Dylan, who kind of helped with setting all this stuff up, my Presbyterian College classmate. This was a unique study. You guys were able to do something that was pretty cool and really put on paper something that we're already doing quite a bit of. And it's exciting to me to be able to highlight some of this work and do it in these very short episodes and very brief. But let's jump into this study. All right, so a little background is sepsis is something that's going to be super, super important across the board due to the high mortality. But I think it's something that we've really gotten to with the new sepsis guidelines, really emphasizing not only the rapid selection, but the correct selection of antibiotics is something we should all be looking forward to. And the study looked at something that was pretty important across the board for just the practice of EM pharmacy and pharmacy in general. Whether having this clinical pharmacy practitioner really helped out when it came to the outcomes when it related to these metrics. Because again, most of the time what we see is when we try to expand our service, when we're trying to expand what we can do, we need some data. And this is one of those papers where you can condense this in and tell your leadership, this is why having pharmacy 24/7 or expansion of what you have can be very beneficial. So Taylor, you guys' research really had one big central question, right? It was, could the involvement of EMCPPs significantly improve the selection and timing of antibiotic administration in septic patients and by extension, the overall management in the emergency department? But the question I have for you is, what inspired you and your team to study the impact of EMCPPs on sepsis antibiotic interventions in itself? Was there a particular case, or was there something that drove this research to get started? Because again, I believe this may have been a resident research, and usually we make those far in advance. So can you shed some light on just the creation of this study in general?
So here in North Carolina, pharmacists can get licensed as clinical pharmacy practitioners or CPPs, and CPPs are approved to provide drug therapy management, including controlled substances, under the supervision of a licensed physician. So our CPP agreement at our hospital covers a few different disease states, and within those disease states, we can order certain medications or labs pending the clinical picture and if we deem that it would be appropriate. In the ED, we've primarily used the CPP service through a culture callback review service, and that had great success. So we started to look for different ways that we could expand our practice even further. When we read back through our original CPP protocol, we realized that it really didn't specify what type of patients that we could treat with antibiotics. And so we proposed this CPP sepsis protocol, and where we could essentially order first dose antibiotics for sepsis patients presenting to the ED, as long as a physician gave us a consult to do that. And so therefore, it really allowed us to expand our practice without having to rewrite a whole CPP agreement through the Board of Pharmacy.
So that's pretty unique. You guys really just took this as a way to get that first consult. Once you got that consult, you was able to order the first dose. That's gonna be pretty unique because that may can kind of impact things later on. But it's unique. You guys went from just the culture callback, which is something that a lot of people are in the process of doing or trying to do better, and using that CPP for that to start off with may be a recipe for success going into the sepsis component. So shout out to you guys for doing that, which is something that, again, I know my shop is trying to do, many others are trying to do as well. So next question for you. You guys showed some pretty interesting stuff. You guys showed that the pharmacist-driven protocol significantly improved the rate of appropriate antibiotic selection from 57% to 86%. That's a big jump. That's really nice, to be honest. In practical terms, what do you think were some key factors that really allowed the pharmacist to optimize the antibiotic selection so efficiently compared to providers? Again, this is not kind of a beef back and forth, but what do you think is some of the factors that led to this finding?
So overall, the ED requires a collaborative care approach. Everyone brings their own perspectives and expertise, including us, the physicians, the nurses, the PAs, the NPs, the techs, everyone. But as pharmacists and the drug experts, when it comes to talking about antibiotic selection, drug therapy is our main focus. And so, especially once we know the source, we do have a little more time to take a deeper look into the chart and really assess the patient globally. So we take into consideration previous hospital visits, culture results, any current labs that we already have back, EKG results, risk factors for certain bacteria. We're clinically assessing these allergies and all relating that back to our antibiogram, and then really thinking through all of the latest literature and guidelines to then quickly decide on an appropriate empiric antibiotic selection. And not to say that physicians can't do this, but that's our bread and butter in the emergency department. So as pharmacists, this is something that we can easily contribute to the team and care for patients better that way.
Yeah, the way I always tell my providers is that we're like a grocery store. You don't necessarily need us. You can definitely do it, but it's sure as heck convenient. And when you're looking at metrics and trying to do all the things that they're trying to do in a single shift, it's pretty convenient to say, hey, the person who spends all of their time looking at drugs and thinking about drugs and who all their training has been doing that, why don't I kind of offload that to them, especially so I can optimize much more of my care. So I think that was a great answer to really offload them to we can kind of focus on one part. And just like we specialize in different areas within medicine for physicians, we specialize in certain things that we're pretty good at. Like we get called every single day on antibiotic selection. So this is only a natural progression of that and how to improve patient outcomes in the long run. So shout out to you guys for doing that. So not only did you guys find the better selection of antibiotics, you guys also found that you did it quicker, which was phenomenal because some people really care about that time to antibiotic, and 64 minutes is not too shabby, not at all. So that was really unique. The next part of all of this is kind of figuring out, okay, we did this great thing. There's no difference in mortality. There's no difference in length of stay. So people can't really kind of clap back and think that one dose and the management that the EM CPP did in the beginning led to any badness in the background. I would have loved, dear God, if you guys would have found a mortality benefit, oh my God, it'd have been phenomenal. So super excited about that part of it. So the study also noted some interesting things that as you dig into, I think a lot of us have issues with to today. They found that UTIs and intra-abdominal infections was an area where we probably could have seen a little bit more efficient antibiotic selection. There was over just prescribing a broad therapy that probably didn't need it. And this is a battle that I fight every single day. And sometimes you have to pick and choose the battle in the war when it comes to these antibiotics and stick with your pneumonias and go from there. But it's something that we should look at and something we got to strategize on. So the question I have for you is like, since you guys found that those areas were probably a little bit more inappropriate selection of antibiotics, what are some strategies they're using to tackle this and partner with the physicians to really help improve antibiotic stewardship in those cases, not just in the ED, but probably throughout the hospital?
Since the study has ended, our hospital has opened a new critical care tower, which has led to more rounding opportunities that previously haven't existed. So our critical care pharmacists now have face time with intensivists and other specialties 7 days a week, which has led to significantly more de-escalation opportunities. Also, CPP agreements at our hospital are department specific. So us as EM pharmacists have our own agreements with the EM providers, and then our critical care pharmacists have their own agreements and protocols with the intensivist. Right now, under their CPP protocol, they can add IV antibiotic stop dates based on guideline recommendations, and then they can also add certain labs like MRSA PCR swabs to help them in their recommendations for de-escalation. But their plan this year is to expand their CPP protocol to really further their antimicrobial stewardship efforts in collaboration with the intensivist.
That's pretty dope, because I think it's something that you guys showed that not only that you do an ED, but you was able to kind of spread that to the ICU as well. So kudos for you guys for doing that. And we're all facing this battle across the world. I know my Australia listeners have the same issues. My Saudi listeners have similar issues. So I think it's something that we're facing all throughout the world, trying to treat UTIs. And I'll put a putt for Sebastian if you're listening. I know you just hate all of those UAs getting drawn in asymptomatic patients. So it's something that we just have to deal with. And whether or not this patient needs any antibiotics is an entire different episode on a Pharm So Hard episode. So let's go ahead and transition to the next question that I had for you guys, is kind of looking at that time to antibiotics being really a crucial. I mentioned before what you guys was able to find. So while your pharmacist protocol did reduce the time to administration again by 64 minutes, there's many patients that didn't get to that 1 hour goal that's recommended by the guidelines, often due to either the acuity of the patient, nursing factors, documentation also being a deal. How do you envision the pharmacist's role really evolving to partner with the team to kind of optimize this treatment time? Or do you have any caveats to your study that really made that time, something that is a little bit more unique?
So I think it's important to note, first of all, that our time to antibiotic administration was not time of sepsis recognition to antibiotic administration. It was time of ED arrival from the time they hit the door to antibiotic administration. This was a PGY2 resident project, and so we thought it would be too grueling of a task to try to identify the exact time of sepsis recognition for each patient in the study. And so when you do look at our results, that number is a little misleading. But overall, after the introduction of the CPP protocol, we did see a decrease in our time to antibiotic administration by about 60 minutes. Once we got the consult, we were able to quickly enter the antibiotic order, but we weren't required to go to the bedside for these patients and help with administration at all. Of course we did for our critically ill patients, and anytime that we had a moment, then we would definitely help the nurses in that aspect. But our biggest barrier to that right now is just we don't have the capacity to do that with just one pharmacist in the ED and a whole lot of action going on. One way I do think that we could dramatically decrease the time to antibiotic administration is by expanding our scope of practice to allow for administration. I know some states like Kentucky are already doing this, and their pharmacists can actually administer medications. I feel like it would be a similar setup with a CPP protocol of some sort, where we would have a certain list of antibiotics or medications that we would be allowed to administer. And I really don't think we're far off from that right now. Our EM pharmacists are already at the bedside. We're calculating these doses, preparing them at the bedside. We're getting the pump ready, programming the pump. The only thing we're not doing is actually pushing the medicine in and hooking the IV lines up. So I'm sure if we were somehow able to combine a CPP protocol with administration, there would be some awesome time to administration studies that would come out.
That's pretty cool that you mentioned that, because I think many people look at the study and say, oh, you guys can get that 1 hour period. If we dig down to that and you have more resources, again, being a resident research project, you have to be feasible. So shout out for Aubrey for all the work she did do for that. And I think if we reanalyze this, you guys probably will find that time being different. But I like what you threw out there about the time to administration and whether who can administer that. There are often times where I trained at Grady in Georgia where I probably gave tens of thousands of medications. So I felt very comfortable with that. And it's something that I know in the state of South Carolina, I was doing as well. North Carolina is a little strange how the law is written when it comes to that. But I think those pharmacists that are, one, able to, and two, have kind of set up a system for them to administer medications, I know for certain that they will be able to find a difference in that time frame. And this is a type of study that we can bring to the people in the suits to be able to say, hey, if my nurse is busy, this is why I'm for one, trained enough to do so, capable enough, and I have the policies put in place to allow me to administer these medications in these vulnerable patients. And I kid you not, if I was every day giving these medications to our patients and I was able to study it, if I was in you guys' shop right now, I know for certain that the time to antibiotic selection administration within that hour will be out the window, because I can get it done in 10 minutes. It's something that I can do once my provider tells me, hey, Jimmy, this is what I'm worried about. Chest x-ray shows this, UA shows that, or whatever the source is. Once they diagnose the opponent and we have all the information, again, pharmacists across the board, that's the definition of Pharm So Hard. We can do this all day. So I'm pretty sure that's a good pump for pharmacists, medication administration. And I think this is a way that we can actually improve patient outcomes on a macro level. And I think that's something that North Carolina and a lot of people are going to be hearing from me pretty soon when it comes to things like this. All right, Taylor. So I don't want to make this too long of an episode, but you guys have one of the first studies looking at outcomes in emergency medicine with this advanced practitioner provider status, CPP. What do you see the next step in research in this area? I know a lot of people are going to be looking for that. My shop is going to be within a year of doing something similar as far as how we set this up as a system. How can profession continue to demonstrate its value and expand on this model of the pharmacist-driven sepsis management and go from there?
I am really excited to see what we as pharmacists can do with these collaborative practice agreements. In regards to sepsis, I can see us managing initial fluid resuscitation, determining specifically which fluids and the volume that we're giving, trying to help prevent volume overload in patients that we send to the ICU. We could also be involved in the initiation and choice of vasopressors. I think there's a lot of room for growth in other areas as well. One that I would be excited about would be DKA and HHS management, discussing initial fluid resuscitation for them as well, insulin initiation, maintenance fluids, electrolyte replacement, bicarb administration. I think that there would be a lot of bicarb stewardship going on if this were to end up in some sort of CPP agreement. Other areas that I could see us getting involved in would be analgo sedation for our intubated patients, maybe acute pain management and opioid stewardship in our EDs, and then even some like toxicology cases. Really any disease state that has a strong emphasis on pharmacotherapy management would be a great opportunity for us as advanced pharmacy practitioners to get involved and make a difference. And I know that a lot of hospitals and emergency departments have protocols where pharmacists are involved and can manage different disease states, but having a CPP agreement really allows us to share our expertise and treat each patient individually.
That's dope. Yeah, and I completely agree with you, Taylor. I think where where we're at and the things that we'll be able to do. I've only been in this state for practicing for about a year now. I think there's so much we can do and so much value that we can able to provide in a way that doesn't take away from what the providers want. Before the AMA comes and arrests me and say that I don't have any expertise in antibiotic selection when I'm dope at that, it's just something that I think that we have the capabilities to do. And if we set these things up with a physician-led team and the protocols being kind of set in that way, I believe that we're onto something. And I think that we can help our physician colleagues, our MPPA colleagues, help our nursing colleagues in a way. I think we're that missing piece to the best possible care in some of these scenarios. And I think the more that we can do, the better off we'll be at the bedside. And I think the better off our patients will be. And I think that the research and the data is going to show that. And it has already shown a lot of that. But I think, again, we have a unique capability in North Carolina with this. And I think we should really try to farm so hard with it and go to the maximum. So I don't want to keep it too long. Taylor, thanks for coming on. Any final words for the audience?
Thanks so much, Jimmy, for having me on the podcast. I really appreciate the opportunity to talk more about our study. And major shout out to Aubrey Hammond, who was our primary author on the study and really did a lot of great work here.
Thanks, Taylor. Shout out to Aubrey again. Shout out to the whole team out there. I've been following Caramount for years and years. They're one of the shops that I really looked up to as far as being small but mighty, again, being a smaller physical size, but always having a ton of people there when it comes to like 24-hour coverage. Some of the research has come out of there. So shout out to you guys. Shout out to all of the EM pharmacy world. And I'm going to continue to try to put out as many of these episodes as I possibly can. Reach out to as many authors that we can. And this is going to be dropping right around the time that we do Empower RX. So in the lovely state of North Carolina. So shout out to everyone there. And you guys know how I close out every episode. You don't have to be a pharmacist. You're not working at ED, but everything you do, make sure you farm so hard.
Closes it. Ozzy scratches his head. Whatever she's looking for, it isn't in there.